Delightful to welcome. It's delightful to welcome everyone to the new academic year. Welcome all the people who've been here. Welcome our new fellows. And as usual, we will start the year with a review of major topics and updates. And of course, we're delighted to have Michael Dial kick this off with ST segment elevation MI. Michael, who's been a fellow, chief resident, and really one of the leaders in our educational program in cardiology. So it's really appropriate that that you're kicking this off. We're really delighted. Welcome everybody, and we hope that the summer series will be a great learning experience for us all. So thank you, Michael.
Thank you for the opportunity to start this off. A bit of an intimidating leap, but here we go. So this topic is important, obviously. We'll go through why, and one of the ones that kind of intimidates us early as we start for those of you who will be in the CCU and seeing patients who come in with ST segment elevation MI, and hopefully the interventional fellows are here as well, because some of this will be helpful for them. So I went through the AHA statistics in 2018 and also 2019, and the numbers are pretty similar. So I didn't change the source here, but there's a lot of heart attacks in this country every year. About 1 million coronary events, 660,000 new, about another 300,000 recurrent MIs. And we certainly know that there's lots of people, especially our diabetic population, who have silent myocardial infarctions. And then that correlates to about every 34 seconds with an acute coronary syndrome, and about every minute and a half, someone in this country dies of coronary artery disease. Societal costs are certainly on the order of billions per year. If you look at this is a pretty dramatic correlation, but looking at ST segment elevation MI, and depending on how you present, whether you present with a normal hemodynamic status or in full-blown cardiogenic shock, your mortality range is quite different, from 6 to about 60%. And if you compare that to a gunshot wound with a mortality of about 20%, it's a pretty striking comparison. And something that we've spent a lot of time as a group taking care of and sort of mastering the systems and guideline-based care, which we'll talk about today. Looking back through the first early definitions and treatments of ST segment elevation MI, you had the clinical observation phase in the early 20th century, which was revolutionized by armchair therapy, which is a wonderful JAMA article if you guys haven't seen it, where they talked about getting and mobilizing patients out of bed early, and they tended to do better. And then you had the development of coronary care units in the 1960s with more advanced therapy such as defibrillation, CPR, etc. The high-tech phase with bedside hemodynamics and Swan-Ganz catheters, and then got into the reperfusion era, which really changed once the diagnosis and pathophysiology of ST segment elevation MI was understood. If you haven't read James Forster's book, The Heart Healers, I highly recommend it. It's an incredible walk through the history of what we do, and many things that we take for granted as commonplace just weren't so. And now we're in the current era of evidence-based coronary care phase with Get With The Guidelines and a number of other things, and lots of publications that come out on a regular basis. We're going to stick to these two eras and not go through too much history. That's for your own reading time. So interestingly, with the push towards primary prevention, medical therapy with statins, blood pressure control, diabetes control, and hopefully a shift in the way in which we view nutrition and health and wellness in general, including mental health, we've seen a decline in myocardial infarction over time, and a decline in ST segment elevation MI. The non-STEMI numbers seem to be kind of flat, and those are holding the bar there. What's interesting though is outcomes have stalled. So around 2008, and then if you take this graph out, there aren't any that are as good as this, but there are a couple that go out to about 2015 and 16. And we're still in this 5% mortality in the short term and somewhere around 15% mortality at 1 year for patients who have ST segment elevation MIs. And we really haven't budged that curve down very much in the last decade and change. So this is where we need to think about how we're gonna improve these outcomes moving forward. There are certainly subsets that have improved, which we'll talk about, cardiogenic shock being one of them. Here's another slide that goes out a little bit further, showing you that similar stall in 1 year cardiovascular death, somewhere around the order of 10 to 15%. Most of this talk comes out of the guidelines, both the European guidelines and the AHA-ACC guidelines with an update in 2015. The Europeans are most up to date in 2017, but they're all pretty similar. I always like when I give a guideline-based talk to discuss kind of the quality of evidence that you see in the guidelines. So if you look over on the left side of the screen, the class 1 level of evidence A is only about 19% of all of the statements that are in guidelines, with many of them being based on less robust data and not fully randomized controlled trials, or at least 2 of them. So STEMI outcomes depend on, I kind of wanted to add a slide here, not having an ST segment elevation MI would be one, but then early restoration of coronary flow, full restoration of flow, both in the epicardium and also in the microvasculature, and then sustained restoration of flow. We'll talk a little bit about that and the medical therapy that goes in before, during, and after. So when we're first faced with someone having a STEMI, we think about the emergency care segment of this. And I included this, that before presentation, we need to talk with our patients a bit about what that would look like. So whether they have stable angina or whether they're at risk for having a myocardial infarction, I don't know that we spend enough time educating them on what a myocardial infarction looks like, what it feels like, and how important it is to seek emergency care. People are often fearful of activating 911, and they think that they're having indigestion or some other things. I recall my own grandmother who had a myocardial infarction when I was quite young, but she spent all night at home saying that she had indigestion from the dinner she had the night before, and this is all too common. So I think that we need to do a really good job of educating our patients about, in the office before they present, about what that looks like and how important their life and well-being depends on early presentation if they have signs and symptoms of an MI. If you look at the process delays to reperfusion, and we know that time is muscle, we've gotten really good at taking care and shortening the system-based delays. So we have pre-hospital activation by EMS. We have STEMI teams that are available 24 hours a day, who are in a pretty good rhythm and able to get to the hospital, activate a cath lab, and get a wire and a balloon in a coronary artery. One of the things that hasn't really changed over time is this patient-related delay. If you look at the GRACE registry, this is going back some time, but again, the data hasn't really shifted. You see that the average time to presentation is on the order of 2 hours, and in some countries even longer than that, out to 3 hours in Argentina and Brazil. And this is for ST segment elevation MI. There are certainly patient factors that are related to delayed presentation, as you see on the slide, women who present atypically mostly, as do the elderly, and then also Medicaid only in minorities, or certainly in a time in healthcare where we're talking about healthcare disparities. And this is one that healthcare disparities also exist pretty significantly. Unrecognized symptoms, some of that is because of atypical presentations, and some of that is because of poor education. And then fear of embarrassment or false alarm, like we talked about. Also, the next part of this is thinking about who uses 911, and only about 60% of STEMI presentations in this country use the EMS system. That's a bit concerning because there are about 1 in 300 cardiac arrests en route. And if you're in a car with a loved one, that they're unable to take care of that, and the longer they are in cardiac arrest, the harder it will be to resuscitate them. And there's a significant association between arrival by EMS and time to reperfusion. There's a number of different factors that play into this, but one of them certainly is pre-hospital electrocardiograms and pre-hospital activation of the STEMI systems. We know that delay to first medical contact has a significant association with mortality. And with about each hour of delay, there's about a 10% increased risk of death, as you see on this slide here. I'm not going to talk too much about initial diagnosis, but we will go into a little bit of it. Some definitions. You need to have signs or symptoms of myocardial ischemia. Chest pain, as most of you know, is not my favorite word. Pressure, tightness, squeezing, heaviness. Use all the things when you talk to your patients, because using just one may miss. You need abnormal cardiac biomarkers that may not be initially, of course, if someone's an early presenter, and eventually they will, unless you're able to abort an MI really early. Persistent ST segment elevation on electrocardiogram is the most important part of this diagnosis here. You need more than 20 minutes, and reciprocal changes are an important component. This is in the absence of left ventricular hypertrophy or a left bundle branch block. We'll talk a word about that down below and on the next slide. At least 2 contiguous leads, of course, with the following cut points, more than 1 millimeter in contiguous chest or limb leads. But if you're looking at leads V2 and V3, this also includes V1, you need more than 2 millimeters in men who are more than 40, and more than 2.5 millimeters in men who are under 40, and more than 1.5 millimeters in women. And a baseline EKG is helpful, but you also want to see typical patterns of ST segment elevation. And again, note reciprocal changes. So left bundle branch block and isolation is not diagnostic of STEMI, and that's been updated in the ACC and AHA guidelines, although it remains in the European guidelines. I think the new term, the new language is most left bundle branch blocks are not known to be old, rather than are new. I think that when the STEMI system gets activated, at least for me when I are early in fellowship, it's this really heavy train that gets going very quickly, and it's hard to stop. And when things are hard to stop, you don't often use your brain and think. So we must realize that although electrocardiographic changes may be present, and although the STEMI system may be activated, we still need to put on our doctor hat often and make a diagnosis. There are a number of different times where we've seen ST segment elevation, and giving anticoagulation and going to the cardiac cath lab would be quite detrimental to someone's health. Active bleeding, that was, I think, published by Nithika as a case report with Boerhaave syndrome and posterior irritation of the pericardium causing ST segment elevation because of Boerhaave syndrome. Anyway, so do a diagnosis. Electrocardiograms are not, the diagnosis is not isolated to those. So there's a couple of EKGs that we shouldn't miss that I thought I'd put in here. So here we see ST segment depression in the anterior precordial leads with a little bit of ST depression, which would be reciprocal changes in the high lateral leads. This can be a pure posterior wall MI or posterior lateral MI. And if you spend a little bit of time and put posterior leads on and wrap around the chest with V7, V8, and V9, you may see lateral wall, posterior lateral wall, ST segment elevation. So burn that one into your memory and make sure that if the clinical presentation is there, then maybe you need to do a little bit of more work with your EKGs to make a more clear diagnosis. This is the classic left main EKG. I tend to harp on this quite a bit. And I say that this is the EKG that you need to put on your doctor hat the most. So this is ST elevation in AVR, and then global ST segment depression. We see this in conference, I would say, about once a month when we talk about it. And we've seen this with just about every kind of presentation that you can imagine. What I usually say is this means something bad is happening, and it's our job to figure out what it is. It certainly can be occlusion or partial occlusion of a left main with a thrombus and acute myocardial infarction. It can also be an aortic dissection, pulmonary embolism, sepsis, severe anemia. We've seen it in just about everything. So this EKG requires thinking. And the last one is a normal electrocardiogram. So if you see a spick and span normal electrocardiogram, but a patient who is 65 years old, hypertensive diabetic, has severe substernal chest pressure, they're diaphoretic and vomited before you saw them, they could still be having an ST segment elevation MI, you're just not seeing it electrocardiographically. And always call for help and get another opinion. So now that we've made a diagnosis and we've talked to our patients before they presented, we need to think about what to do in the initial phases before we get to the cath lab and think about reperfusion therapy. So that's relief of pain, breathlessness, and anxiety. So these are all drivers of sympathetic tone, which in turn increases myocardial work. If we think about the physiology of what's going on, we have a complete lack of supply to oxygen to oftentimes a large myocardial segment. And then the body's response to that is to work harder because there's usually decreased pump function. And then all of the other things associated result in severe catecholaminergic surges. And that's going to increase heart rate, it's going to increase contractility, and it's going to increase vascular resistance. All of those make the myocardial want more oxygen, and that's in the absence of supply. So if we can help blunt some of those responses and decrease some of the sympathetic output, we may be able to protect at least some of the myocardium that lacks a supply of oxygen. So in terms of relieving ischemic pain, nitrates, you need to consider the patient's hemodynamics. You need to make sure if that they're not having an RV infarct, and the use of phosphodiesterase inhibitors recently should be part of our history. Narcotics, morphine is the drug of choice. We tend to not pull that quickly because we're able to activate our STEMI system and get to the cath lab. But if someone is having persistent pain, morphine would be the drug of choice there. Relief of breathlessness. So oxygen is helpful in the hypoxemic patient. So you don't want to give oxygen necessarily to everyone, as it can cause a little bit of vasoconstriction in the coronary tree. But if they do have low oxygen saturation, somewhere on the order of 92% or so, and they are breathless, oxygen can help with that. Anxiety, so reassurance as they're talking to patients, as they're seeing a bunch of people rush around them. It's a very intimidating environment. So making sure that either one of us or some part of the team is talking to the patient. And then of course, anxiolytics. By the time they get to us, they usually get a benzodiazepine and a narcotic, but that could be given earlier if there's any kind of delay. A note on cardiac arrest, which is not so uncommon in the setting of STEMI. About 5% of those who come to the hospital will experience cardiac arrest at some point, and high volume PCI centers report on the order of 4 to 11% of patients with STEMI are brought to the cath lab after being resuscitated. Certainly during fellowship and such, we've done it in the ER, we've done it in the elevator, which I don't know why it always happens there. And then of course, as soon as patients get to the cath lab, oftentimes defibrillation is part of our routine. Again, something that we take for granted if you take a look back through history. Out of hospital cardiac arrest victims with ventricular fibrillation who survive to admission have about a 60% survival with early PCI. And one of our former fellows wrote a very nice paper talking about coronary angiography, which has increased over time in out of hospital cardiac arrest. And there seems to be an improved survival with that. We can talk about that later. Now, lastly, and what most people think about when we talk about STEMI are reperfusion strategies. Actually, when I first made this talk a few years back, I said, or when I was studying for the boards, reperfusion strategies was a confusing topic to me. I thought it should be singular, that everybody gets PCI, but that's not necessarily true, and especially in the time of COVID, as we'll talk about. So myocardial reperfusion as primary therapy has been known for quite some time. And if your three options are fibrinolysis, pharmacologically, primary PCI, and acute surgical reperfusion. Going back to only 1999, which is really not so long ago, if you look at any reperfusion therapy, only 2/3 of patients with STEMI received that. In the ACTION registry, it was up to 94%, and I believe it's even a bit higher now. Looking at primary PCI in 1999, that was only at 15%, and now it's at 83% of patients who present with STEMI and receive reperfusion therapy. Fibrinolysis was at about half and has gone down to where primary PCI was, so those two curves have shifted with very good data to support that. All patients should undergo rapid evaluation for reperfusion and have a reperfusion strategy implemented promptly. Time is certainly the most important part of this. So Bernard Gersh with Greg Stone and colleagues reviewed multiple trials of reperfusion therapy to derive insights on therapy efficacy for patients presenting to hospitals without primary PCI. So this is looking at fibrinolysis. And they developed this hypothetical curve relating the duration of symptoms before reperfusion to reduction in mortality and extent of myocardial salvage. So during the first 2 to 3 hours, as you see here in this, I guess, darker red color, this is the critical time-dependent period, and your goal is myocardial salvage. So this is when you have not suffered irreparable damage in myocytes, and reperfusion can have full restoration and survival of those myocytes. So this is where time really is the most important thing. And occasionally, we don't often ask, but we should ask every time, especially for those of you who are first with patients, when did your symptoms start? And there's a little bit of a difference between stuttering angina and then all of a sudden when it became persistent. So being a little bit nimble with your history taking and understanding when do you think that artery has become completely occluded and led to ST segment elevation. And that doesn't necessarily have to include the stuttering part. And so at this time, we need to really get to the hospital quickly and try to save as much muscle. After this, the mortality benefit decreases in magnitude over time, and the goals of therapy tend to change. So these become time independent period where you want to open the infarct-related artery, improve infarct healing, improve electrical stability, and salvage hibernating myocardium. So although this was developed for the concept of fibrinolysis, it still holds true with primary PCI, although the curve may be shifted a little bit more to the right. So again, thinking about how in the world is fibrinolysis a part of our system, we have 3 cath labs that are capable of doing primary PCI on this block, but that's just not representative of the entire country. So in fact, most US hospitals do not have PCI in general, and certainly not primary PCI. And only about 36% of acute care hospitals have primary PCI. About half of our population in the US, a non-PCI is the closest hospital, a hospital without PCI capability is the closest to them. And the median average added drive time to a PCI center was 11 minutes. And this is how important the STEMI system and STEMI networks that have been developed, how important they are, and how early recognition by our first responders in EMS, being able to recognize ST segment elevation MI and even diagnose it electrocardiographically, so they then know to take them to the proper hospital. And there are a certain percentage who lived within 60 minutes of a PCI center. So that's a big deal as we think about primary PCI as the only strategy. It really isn't. And we need to keep the fibrinolysis in our back pocket, depending on where we end up practicing. So what about fibrinolysis versus no therapy at all? Just to remind us, there's lots of data. This is 9 randomized trials, 58,000 patients, and a summary of those, looking at the number needed to treat, and here at the end, number needed to harm, which we'll make a point. So in all patients, you see a benefit to fibrinolysis over placebo. If you look at patients with new bundle branch blocks or anterior ST segment elevation MI, these are large infarcts, you have a pretty significant benefit to fibrinolysis over nothing. If you go to the inferior wall, there's a little bit less benefit, and that's because those infarcts are slightly less devastating in terms of mortality or less severe. And if someone has ST segment depression only, so a non-ST segment elevation MI, and you give them thrombolysis, the number needed to harm is only 71. So this is an absolute contraindication. It's only given to patients with ST segment elevation MI. In the 2013 guidelines, looking at what it says in regards to fibrinolysis, if there's an anticipated delay to performing primary PCI within 120 minutes of first medical contact, then there's a class 1 indication to give fibrinolytics with the onset of symptoms being less than 12 hours and anticipated primary PCI, as we said, within 120 minutes. A class 2A if PCI is not available and clinical and/or ECG evidence of ongoing ischemia within 12 to 24 hours of symptom onset in a large area of myocardium at risk or with hemodynamic instability. This gets a little bit more dicey, but can be there. And then we talked about how in the absence of ST segment elevation, unless it's that pure posterior infarct that we talked about earlier, it's class 3 with potential harm. I'm not going to read through this slide, but you should at least have somewhere in your iPhone or easily accessible the absolute and relative contraindications to fibrinolysis. What about adjunctive therapy if you do give fibrinolytics? So this is something that I find that there's a little bit of confusion. It's absolutely on the boards, both the general cardiology boards and then also interventional boards. Anticoagulation therapy for a minimum of 48 hours and preferably for the duration of the index hospitalization up to 8 days or until revascularization. This is after you've given fibrinolysis. You have a class 1C indication for unfractionated heparin and a class 1A indication for enoxaparin. We almost never use fondaparinux, which is Orixtra. I don't even think it's on any of the formularies anymore. It used to be on Jackson's. But if patients are going to end up in a cath lab, fondaparinux has been associated with increased catheter-related thrombosis. So that should not be given, but enoxaparin with a slightly higher recommendation. And then antiplatelet therapy is important because we have an array of available P2Y12 inhibitors. Aspirin should certainly be given with an initial loading dose as we usually do. And in terms of P2Y12 receptor antagonists, clopidogrel is the drug of choice. This has not been studied with the more potent P2Y12 inhibitors, prasugrel and ticagrelor. If you're going to give clopidogrel in the younger patient population, you want to give a 300 milligram loading dose. And if they're over 75 years, no loading dose, just start 75 milligrams a day. And there's some of the data below. So just if thrombolysis is a primary reperfusion strategy, here's a summary. The drugs that we have on this campus at UM and Jackson, you have tenecteplase, which is a bolus infusion that's given over 5 seconds. At the VA, we have alteplase, which is given over 90 minutes. There's 3 different doses, and I can share with you a slide deck that has that, if you'd like. Adjunctive antiplatelet therapy, aspirin and clopidogrel, like we just talked about, and also an anticoagulant, such as enoxaparin or unfractionated heparin. The limitations of thrombolysis is that there are a handful of contraindications, and only a certain percentage of patients are going to be candidates for reperfusion therapy. A failure of complete reperfusion in 50 to 60%. This is achieving TIMI3 flow, so it's certainly less effective than primary PCI, but it is better than nothing, as we studied. There is a higher incidence of reocclusion, and of course, the thing that everyone fears is about a 1 to 2% risk of hemorrhagic stroke. The advantages are it's universally available. It's preferred when PCI is not available or delayed more than 120 minutes. So you can imagine field hospitals, smaller third world countries, cruise ships, et cetera. There's lots of places, and more rural areas, lots of places where this would be important. And very effective in early presenters and far less effective later in presentation. I'm certainly not going to go through all of this data, but it's been studied extensively, primary PCI versus thrombolysis and STEMI. This is 23 randomized controlled trials and just under 8,000 patients, looking at the advantages of primary PCI, both short and long term, over thrombolytic therapy, and certainly decrease in bleeding and stroke. What about door to balloon time, which we spend a lot of time talking about? If you see here, this is a cutoff at about 90 minutes. Your curve for in-hospital mortality starts to increase. Most of the guidelines have consistently say 90 minutes is our goal, but we've shifted that down to 60 minutes internally trying to achieve. Dr. Cohen has said a couple things. I'm not entirely sure that ticagrelor and prasugrel weren't studied in STEMI. Oh no, correction, sorry. Yeah, clopidogrel is the antiplatelet drug of choice with fibrinolysis. So talking about, again, door to balloon time is important, and this goes back with your time is muscle, and early reperfusion is better. So in a part of the guidelines, like I said, less than 90 minutes is written here, or 120 minutes. If they first presented to a non-PCI capable hospital and they were transferred, the goal shifts to 120 minutes, obviously earlier being better. And there's a push to this 60-minute from first medical contact to device time. Looking at asymptomatic patients presenting between 12 and 24 hours after symptom onset, they are at higher risk for complications. However, it looks like you can decrease infarct size with PCI, but no change in hard outcomes. And then we can talk a lot more later about a totally occluded infarct-related artery that's been occluded for more than 24, really 72 hours is the OAT trial, and what the benefits to reperfusion are there. Just a note on multivessel disease, pulpit versus multivessel disease in PCI and STEMI. So looking at 28,000 patients from 8 clinical trials, a lot of patients who present with ST segment elevation MI will have concomitant non-infarct related artery significant obstructive disease. In here, it looks at about 53%. And if you do have non-infarct related artery obstructive atherosclerotic disease, there seems to be an association with an increased mortality, long-term mortality. This is going out to 30 days, and then this curve continues out to a year. So this is a significant problem that was then studied. 3 major trials published in the last 7 years first with Prami in 2013, Dynami Primolti in 2015, and then the Culprit trial in 2015. And what they all showed were similar curves, with complete revascularization showed a mortality benefit compared to incomplete revascularization. They all had slightly different definitions of when that was done, how it was done, whether it was during the index procedure, index hospitalization, or within the first 30 days. And this becomes more of a clinical decision-making and even heart team decision-making in patients who present with STEMI and have significant non-infarct related disease. One of the things to take note of is the evil humors of STEMI and the metabolic milieu that is then generated oftentimes create vasoconstriction and will make other vessels look to have more severe disease than they may have when things have settled out. And we've seen that a handful of times looking at bringing patients back for complete revascularization, and then vessels don't look nearly as significant as they did during that first angiogram, and depends on how sick they are and what drugs they're on also. So there has been in 2015 an update to the guidelines where it used to be class 3 and potential harm to fix non-infarct related arteries. It has now become a 2B. That's in the setting of the index procedure or even right after. There's a note down here that multivessel PCI in all patients with STEMI and multivessel disease, this is not endorsing that as routine. Rather, when considering the indications for and timing of multivessel PCI, they should integrate clinical data, lesion severity, complexity, and risk of contrast nephropathy to determine the optimal strategy. So again, and as most of you will learn as you rotate through the cath lab with all of your faculty here, this is a cerebral game more than a technical game, and making good decisions is the most important part of our job. So where did that 120 minutes for PCI related delay come from? And there's a good amount of data looking at how this is where primary PCI would be better or fibrinolytic therapy better in terms of outcomes. And these are the odds of mortality or death with fibrinolysis. So your odds of death are much higher in the earlier phases, but then these lines cross at about 120 minutes, where the delay to primary PCI then seems to be worse than giving upfront fibrinolysis. So that's where that 2-hour mark comes from, where earlier reperfusion is better. And if earlier reperfusion means fibrinolysis, then that would be the optimal strategy. This does not mean that you give fibrinolysis within 2 hours. You still give it within 30 minutes of presentation if you can't get to primary PCI in that timeline. So what happens if you do present to a hospital that does not have primary PCI? And this is where the concept of the DIDO time, or door in, door out time. So if that goal is 30 minutes, and if you look here, if your door in, door out time is less than or equal to 30 minutes, you have about a 60% chance of getting a door to balloon time of less than 90 minutes, which is the goal anyway, and about a 91% chance of a door to balloon time in less than 120 minutes. Look at the dramatic difference between getting out of the door in more than 30 minutes comparatively. Less than half of the patients are going to get a door to balloon in 120 minutes. And that's, you would rather give fibrinolysis. So it's really important to have a system in place in non-primary PCI capable hospitals for early transfer and make that smooth and as painless as possible. If you look at mortality with door in, door out times, and you have patients who are sent out in under 30 minutes, mortality is significantly affected compared to those who are sent out less than. Again, all going along with time is muscle, and the more muscle salvaged, the better your chances of surviving. So here's a short summary slide. I think we've talked about this kind of ad nauseum about patients seen at non-PCI capable facilities and whether they should be transferred or given fibrinolytic therapy. So fibrinolysis, although it was important to study for the boards, and maybe we would be consulted by someone in a more rural area or talk to some of our colleagues, it has become much more relevant in the era of COVID, and there's been lots talked about. Dr. Cohen has taken a huge lead with SCAI and ACC here in a couple of publications talking about reperfusion strategies in patients with COVID-19. This is a complicated topic with lots of controversy across the country, but we have a lot to think about in terms of protecting ourselves and protecting our staff to make sure that we have a cath lab for those who need it. And this was developed by Dr. Cohen and a few colleagues at the University of Miami Health Tower, with an algorithm on how to handle STEMI patients with COVID or whether they're patients under investigation. So we can talk more about this as we go on through the first months of fellowship, but this is something important to take into consideration. Pharmacologic therapy in the setting of STEMI. So we're not done in the pre-hospital setting or in the cath lab. I think the most important part is going to come afterwards. So primary PCI, pre-cath lab adjunctive therapy. We know that we give aspirin and a P2Y12 inhibitor loading as soon as possible. There are times when we think about P2Y12 loading and the risk of patients needing CABG. In the setting of STEMI, we tend to fix the infarct-related artery anyway, and then can handle the CABG-related issues with a P2Y12 inhibitor later if that's needed. The loading doses are there for you: 600 milligrams of clopidogrel, 60 of prasugrel, and 180 of ticagrelor. The anticoagulant of choice is almost always unfractionated heparin. And G2B3A inhibitors are really reserved for bailout strategy in the cath lab and should not be given up front. There's plenty of data to support that. There's more harm than good that's done. A little bit about beta blockers, which we all talk about and emergency department physicians often ask, or at least maybe we should have that conversation with them when we're on the phone initially. So this is an old slide from Circulation in 1977 by Robert Jennings and colleagues, where they looked at the duration of occlusion and the progression of infarct from the subendocardium to the epicardium. And as you see, at 40 minutes, you start to see necrosis in the subendocardium, at 3 hours in the mid-myocardium, and then at 24 hours, complete infarct. And this is called the wavefront phenomenon of necrosis. This was studied in dogs, unfortunately. In the same journal, they gave these dogs that they were studying either no treatment or placebo. They gave them propranolol treated after 3 hours of infarct-related artery, and then pre-treatment with propranolol. And you see a significant reduction in infarct size in the dogs who were pre-treated with propranolol, even a reduction in those who were treated after the infarct was initiated compared to those who were untreated. This is 1977. In the last 5 decades since then, we have seen so many ups and downs with beta blocker therapy initially in the setting of acute ST segment elevation myocardial infarction. In the pre-reperfusion era, you have 2 trials where you see a reduction in enzymatic infarct size in the Gottberg, metoprolol, and the Miami trials. And in ISIS-1, there was only 5% of patients discharged on antiplatelet therapy. So obviously not a contemporary population. In the reperfusion era, there's, again, this controversy that we talk about. So more heart failure with atenolol, TIMI 2 to 5, lower reinfarction with immediate versus day 6 metoprolol. So that's early metoprolol administration versus day 6. You get a lower reinfarction rate, although this is before anticoagulation, clopidogrel, and PCI. In the Gusto-1 trial, IV atenolol resulted in more death, heart failure, shock, and recurrent ischemia and pacemaker use than oral atenolol. And then recently, more recently or more contemporary, you have early intravenous therapy with metoprolol in almost 50,000 patients. This is published in Lancet. This is the COMET trial. They saw a decrease in reinfarction and ventricular fibrillation, an increase in cardiogenic shock, especially in the first day of therapy. You have in 2013 the MEDOCARD trial, where they saw a decrease in infarct size, an increase in left ventricular ejection fraction, and no adverse events. And this is the effect of early metoprolol on patients undergoing primary PCI. And then in 2016, you have the BAMI trial, where they saw no reduction in infarct size, decrease in malignant arrhythmias, and then no harm seen. So we go back and forth again with beta blocker therapy. Conceptually, it makes a whole lot of sense, right? Beta blockers are the drug of choice when it comes to decreasing myocardial oxygen demand, and they do a great job of that. Although we have to balance the risks of what hemodynamic effects they're going to have on patients presenting with acute myocardial infarction, specifically cardiogenic shock and heart block. In the guidelines, I'm not going to read through all of this, but IV beta blockers have inconsistently reduced infarct size and have not reduced mortality rates in clinical trials. In some trials, they've been associated with some harm. So I think that most of us, at least in my education through here and what I've seen, IV beta blockers tend to be avoided in the early stage. And then you want early onset of oral beta blockade in patients who are hemodynamically stable and who have been revascularized. If anyone wants to make a comment afterward, that would be great on beta blocker therapy. This was recently published, or not too long ago, published out of the European Society of Cardiology, looking at key treatments between 1995 and 2014 in STEMI. I'm not going to go through all of these, but it's dual antiplatelet therapy, ACE-ARBs, prior PCI, beta blockers, statins, coronary angiography. And you see that as these treatments increase in percentage, we've seen a significant decrease in mortality. With that stagnation around 2008, 2010, we can't get below that 5 to 6% mark. So we've done a lot in terms of evidence-based medicine and implementing these strategies in most of our patients who present with STEMI. We need to somehow break through that 5% mark. The last couple of slides are just to touch on some of the major complications and some of the other issues surrounding ST segment elevation MI. I think the first thing to talk about in terms of complications is cardiogenic shock. The etiology of shock in STEMI patients, it's either pump failure or due to mechanical complication, and pump failure can be LV or RV, as you see there on the third part of that. About 15% of patients at presentation and 85% during hospitalizations. I think that's really important to take note of, because just as your patient came through with STEMI, they went to the cath lab, they got revascularized, that doesn't mean you're out of the woods in terms of hemodynamic complications and cardiogenic shock. And we need to keep a close eye on these patients in the CCU. Obviously, mechanical complications can often tend to lead to cardiogenic shock. There's a bimodal presentation with the majority occurring less than 24 hours. These are late presenters or reperfusion effects. And then the remainder in the first week of STEMI. And again, we need to communicate very well in terms of time of onset of symptoms and the risk of a major mechanical complication. RV infarction, obviously very important. We should look at that initially in inferior wall MIs, looking at V4R and also echocardiography. These patients tend to present with hypotension, clear lung fields, and elevated neck veins. The survival benefit to acute coronary revascularization in patients presenting with shock is well established and continues to be so. This is the only real therapy pharmacologic and or I hope I didn't freeze for too long there. I just noticed my screen clicked. Pharmacologic and or mechanical support are a separate talk in and of themselves, and you will get plenty of that during fellowship and hopefully during this early phase also. But patients presenting in KILLIP 2 to 3, dopamine and or dobutamine, and KILLIP 4, norepinephrine tend to be the recommended drugs of choice. And again, that's going to be nuanced according to patients. Medical support with inotropes and vasopressor agents should be individualized and guided by invasive hemodynamic monitoring. Swan-Ganz catheters are not dead, and they should be used in patients in cardiogenic shock and advanced heart failure. The use of dopamine in this setting may be associated with excess hazard, just as a guideline. This is from the ACC and AHA. Looking at advances in STEMI care and patients presenting with cardiogenic shock, one of our colleagues, Bill O'Neill, who is near and dear to many of us here, as he was here for quite some time, has led the charge in hemodynamic support in patients presenting with acute MI and cardiogenic shock, first via the Detroit Cardiogenic Shock Initiative, which is now shifted into the National Cardiogenic Shock Initiative. And they're seeing in some of their published and unpublished data, a really significant increase in survival in patients who have early implementation of mechanical circulatory support, typically with an Impella device. This is, again, for something a bit different, but it has to do with hemodynamic monitoring and mechanical circulatory support early. Some other complications of STEMI, severe mitral regurgitation, whether that's because of a frozen papillary muscle and acute MR, or a ruptured papillary muscle, LV free wall rupture, ventricular septal defects, and LV aneurysms. Diagnosis is almost always clinical with physical examination, and then, of course, echocardiography. Prompt surgical consultation and repair with or without CABG is indicated in most of these cases, but again, taken on a case-by-case basis depending on the patient's chances of survival. Intra-aortic balloon pumps can provide temporary circulatory support in some, and depending on which of these that a patient presents with, further mechanical circulatory support with Impella, either right or left-sided, can be important. My last slide here is going back to the phases of STEMI care. I see Sabine Gempel here, who is one of the physical therapists who work in cardiac rehab. I think I saw Jessica also. So pardon me for not putting cardiac rehab in this slide deck, but it was getting excessive in terms of slide numbers. But I think post-discharge, as we talk about pharmacologic therapy with statins, ACE-ARBs, antiplatelet therapy, and beta blockers, cardiac rehab must be an essential part of patients who in the post myocardial infarction care be a part of. There's a significant mortality reduction in patients who go to cardiac rehab versus those who don't. And there's a huge psychological and social benefit to an education benefit to going to cardiac rehab. So it's part of our order set, and patients love cardiac rehab both during and many stay for phase 3 cardiac rehab afterwards. But going back to this, the future phase of STEMI care, we're in the setting of a really unique and generational public health event with COVID-19. It's really in our face. It's everywhere. It's making our whole society change our behavior. We wear masks, and it's really obvious. A concerning thing is coronary artery disease and the risk factors that lead to coronary artery disease, and then ST segment elevation MI, have been a global pandemic for quite some time, not just in developed countries, but certainly increasing in underdeveloped countries as they take on Western diets and Western activities. So I hope that one day one of you can give this talk, and the era of STEMI care that we'll be in, or that phase, will be in the public health primary prevention era, where we focus on overall sort of system human well-being and prevent a lot of the risk factors that have been plaguing our society for some time. Coronary artery disease is by far and away the leading cause of death in this country and in the world. And it's because we're not doing a great job up front with primary prevention. So this is underrepresented in the literature with less vigorous science, despite knowing it is of the utmost importance for public health. Everything you read will say how primary prevention is important, yet we don't necessarily implement that into our daily lives. So that's the last bit of my soapbox there, moving forward. And thank you for the opportunity to present the first grand rounds of the year.
All right, Michael, thank you so much for that wonderful overview. So we'll have take some time for questions. I'd like to ask you one question. You threw out a little bit of a teaser there in terms of our outcomes post-MI have plateaued, both acutely and long-term. So do you think that they've plateaued because we're now delivering perfect therapy, or are we missing some? We have a whole cadre of therapeutics that we're now throwing at people. Are we missing something?
Yeah, you know, that first slide where you look at the overall process to delivering STEMI care and time to reperfusion therapy, I think that we've gotten almost as good as we can get in terms of a system delivery that's pre-hospital with EMS systems, emergency departments, and cath labs. We're really consistently under the 60-minute mark on this campus and across the country and world, I believe, although I can't say that very well. I think the thing where you look back at that the GRACE registry, where time to presentation remains at this 2-hour mark, and it's always what we see. It's so infrequent that we get that, gosh, I've had symptoms for 20 or 30 minutes and I called 911 and now I'm here in 40 minutes. So I think education would be the biggest area where we could probably knock off a percentage point or two if we can get the majority of people presenting within that first hour for complete myocardial salvage. There's people studying whether or not early implementation of mechanical circulatory support outside of cardiogenic shock is helpful. So if you put an LV support device in early in anyone having an anterior wall MI or a large anterolateral wall MI, and then you're able to give IV beta blockers and do other things, maybe that's going to be helpful. So that's being spearheaded by up in Boston by Naveen Kapoor And Carlos can probably talk a bit better than I can about that. So no, I don't think we've reached perfection at all. I think that there's a lot of work to do. Maybe that's in public health and public education more so than in science, although our science can definitely get better. Someone wrote here, the last study on complete revascularization in STEMI from Canadian Registry published this week found that complete revascularization ACS patients associated with a 22% reduction in composite of all-cause death or new MI. Oh, thanks for sharing that. I didn't see that. Yeah, you know, it's so funny with these. This is something that I find interesting, and maybe I'll open it up to the other interventionalists in the group here. But we have this STEMI data showing complete revascularization is better than not. But then this is on the coattails of ischemia, the ischemia trial, where we're saying that it's okay to manage these patients medically and there's no difference in mortality. I find the juxtaposition a bit confusing, unless we're saying that patients with acute coronary syndromes are a different subset of chronic stable ischemic heart disease and more susceptible to plaque rupture and therefore death. But I'd love to hear more. And if you want to have a comment before someone else does on beta blockers, that'd be great.
Michael, this is Mauricio Cohen. So in terms of the type of plaques that patients with STEMI have, they're different. And the reason, and that has been studied with OCT, and the plaques are more vulnerable. And that's a reason why they may benefit. And it's an acute coronary syndrome is a completely different animal than the patients that were entered in the ischemia trial. So that's apparently seems to be the difference.
Yeah. So
yeah. Hey, Michael, this is it's Carlos. I just to dovetail on Mauricio's comments. I think that, you know, if you look back at the Prospect trial, we know that about at 2 years, 15% of patients that have an ACS will have another event, and about half of those are related to the infarct artery, while half are related to the non-infarct artery. But many of those have markers of vulnerable plaque. So absolutely, the ACS patient is a totally different patient than a stable CAD patient. And in regards to the complete revascularization versus incomplete revascularization, there's a fair amount of data that, you know, early complete revascularization for non-shock patients, you know, is beneficial. But looking at you know, some of the data, you know, what kind of confounds me is if you look at the shock and acute MI data, there seems to be a lack of a benefit, you know, at least from the one trial that we do have. Now, there's lots of subtleties of that trial. For example, they were obligated to attempt CTO revascularization in the study of STEMI. There was increased contrast load and increased renal insufficiency. So there's some trial-related you know, differences there, but I think it's important to keep that in mind.
Yeah, lots. There's so many other talks that can be given off of this. Yeah. That are important to address. Dr. Cohen, I agree with you that these ACS patients have an interesting pathophysiology in terms of vulnerability with plaque rupture. So where are we going to go in terms of diagnosis, whether by non-invasive imaging techniques or invasive imaging techniques, with the vulnerable plaque? And if we say that it's effective in preventing future events, that revascularization is effective in preventing future events in this ACS population, are we then assuming or thinking about how that could affect the vulnerable plaque before someone has an ACS?
I mean, that's very difficult. That's very difficult to predict. I think that many people are working on molecular imaging. I think that the thing is that those things don't catch on to practice. That many of those things are experimental. What was that technology you guys had in the VA to detect a vulnerable plaque, and that was approved by the FDA?
Oh,
Nears IVUS, yeah.
Yeah, that company I think went belly up. I don't know what you did with that machine.
It was purchased by a Japanese company actually, and so they've kind of strategized. And actually, there was some data that Manos Berlakis and his group published. You know, we were kind of initially participating in the trial at the VA a few years ago, but some of that data finally came out, you know, showing that increased lipid plaques, based on near infrared spectroscopy, is predictive of future events, and we could use that, to predict future vulnerable plaques.
Yeah, so that's interesting. But again, I mean, the patients in the ischemia trial are completely different than patients with, the biology of those patients with acute coronary syndrome.
Right. Right. Dr. Goldberger, what are your thoughts on beta blockers?
Wonderful question, but that, as you said, that's a whole topic on itself.
Right.
I think there's, you talked about the intravenous use, and obviously the data is very conflicting. I know we rely a lot on COMET, but I think you have to be very careful about looking at the COMET study, because the way they administer beta blockers is not a manner in which any normal cardiologist would do so. They, gave early beta blockers and then very rapidly ramped up to full dose beta blockade. So again, I know they had, almost 50,000 patients, I believe, and it's a big study, but I'd be careful about applying that in our care pathway. In the long term, there's a lot of questions still about, beta blockers in terms of dosing, in terms of how long they should be treated, who should be treated. Most of the data that we have on beta blocker therapy are on the benefits of beta blocker therapy really come from studies that were done 40 years ago. That was at a time when virtually none of the important therapies that you've discussed today were in existence. I think there is a role for beta blocker therapy after MI, but I think we're going to be seeing a lot of new questions and a lot of trying to figure out how to do it better.
So one thing, as these lectures are mostly geared towards the first-year fellows that are starting to see patients acutely in the emergency room while they're covering the CCUs, my recommendation would be not to give IV beta blockers in acute patients that present with STEMI, because you can, once I remember this is an anecdote, a patient presented with tachycardia. And their first reaction was to give a beta blocker. They tipped that patient over full-blown cardiogenic shock. The patient was having a tachycardia because it was in Helix 3. And once they gave the IV beta blockers, they had to intubate the patient. The patient completely crushed, and he had an ejection fraction of 10% with a severe left main STEMI. So I think that beta blockers are beneficial, especially on patients that have residual LV of less than 40%. I think that there are trials that have shown that carvedilol works. What was the name of that trial? Capricorn. So they're indicated. For patients with preserved ejection fraction, I think the data is more conflicting, right, Jeff?
Yes.
So you always have time to give beta blockers once the patient is stabilized. If you don't know if the patient is stable or not, just don't give it. Maybe the only situation is when you know that the patient has preserved ejection fraction and is very hypertensive and tachycardic in the hyperdynamic situation. But you need to have a good clinical eye to make that distinction. So you can, all these STEMI patients will end up in the cath lab, and you can defer that decision to whatever is happening in the lab rather than give it right away. Maybe sometimes the ER doctors, they like to do stuff and they will push you to they like to do stuff and they'll want you to do a beta blocker or an IV beta blocker, just resist that compulsion.
So, Mauricio, this is Alan. I mean, would you tell your team that no beta blockers at all on patients who come into the ER with STEMI who are hemodynamically stable and not in clinical heart failure?
No, I don't think that IV beta blockers acutely are well backed by evidence. And then the last trial that Michael, that I thank Michael for bringing it up, that early VAMI study did not show a reduction in the primary endpoint, which was emphasized by CMR, by MRI. So I don't think you're doing much. I mean, you may decrease some ventricular arrhythmia, but that you're not decreasing mortality, you're not decreasing infarct size by giving IV beta blockers. And some patients, if you don't diagnose them well, some patients may be tipped over to cardiogenic shock. So you have to do it very carefully.
What about PO?
What about what?
Oral.
Yeah.
Oral.
Oral, yes. Oral, yes. The following day, once the patient is stable, I'm against giving it acutely IV in the ER.
Well, I mean, as you know, Michael showed, I mean, beta blockers are one of the few things that have been clearly shown to reduce infarct size overall. And so I wonder if there should be some sort of algorithm for patients who present who would potentially benefit and who might not be over into shock or heart failure. And I think that it's important to note that there probably are subsets of patients who would benefit from beta blockers at the initial encounter.
What do you mean initial encounter, in the ER, IV, or orally?
Yeah, orally at the initial encounter. I agree that IV beta blockers may be a bit too far, but there probably are some patients who would benefit from starting it in the emergency room of PO oral beta blocker. Obviously,
Yeah.
one very important point you mentioned is the heart rate. Obviously, when patients are extremely tachycardic, that's a bad sign. And they potentially are patients who could fall into shock or pulmonary edema, and I think you have to be very careful with that. But I think it would be worthwhile to consider making an algorithm for patients who would potentially benefit and maybe have the emergency rooms sign off on that, so we don't have problems with patients being inappropriately treated or with either starting beta blockers when they shouldn't or not starting them when they should.
Yeah, but then if you give them orally, Alan, I mean, what's going to be the absorption? I mean, we're struggling with absorption of P2Y12 inhibitors in STEMI, and there's a whole controversy on the use of opiates. So if you give it orally in the ER, I mean, what's going to be the absorption? So you have time. I don't think, and then that VAMI study that Michael alluded to showed that there's no differences in infarct size. It's very difficult to decrease infarct size with adjuvant therapies beyond reperfusion in STEMI.
Okay, so I think we can clearly see that there remains controversy about the use of beta blockers acutely. We're certainly not going to resolve that today, but I want to really thank all the participants, and it was great discussion as well afterwards, and thank you, Michael, for a great presentation and discussion.
Thanks,
Have a good day, everybody. We'll see you next week.
Bye.